So, good morning everyone. Today we will be discussing about ventricular dysrhythmias. So, before we carry on to the discussion, I would like to have a reviewer on the normal values of a normal rhythm. So, a normal sinus rhythm is an electrical conduction that begins in the SA node, which generates a sinus rhythm. Normal sinus rhythm occurs when the electrical impulse starts at a regular rate and rhythm in the SA node and travels through the normal conduction pathway. So, ang normal values would be ventricular and atrial rate 60 to 100 beats per minute for the adult. Ventricular and atrial rhythm, regular. QRS shape and duration, usually normal but may be regular abnormal. P wave would be normal and consistent shape, always in front of the QRS complex. PR interval, consistent interval between 0.12 and 0.20 seconds. The P to QRS ratio would be 1:1. Next, let's have an overview of dysrhythmia. So dysrhythmia are disorders of the formation or conduction or both of the electrical impulse within the heart. These disorders can cause disturbances of the heart rate, the heart rhythm, or both. Dysrhythmias include sinus, atrial, junctional, and ventricular dysrhythmias, and their various subcategories as well as conduction abnormalities. So today we're gonna discuss about ventricular dysrhythmia, which is the focus of my reporting. So, a ventricular dysrhythmia is a disturbance in the normal rhythm of the electrical activity of the heart that arises in the ventricles. So, ventricular dysrhythmias originate from foci within the ventricles. This may include premature ventricular complexes, ventricular tachycardia, ventricular fibrillation, idioventricular rhythms, and ventricular asystole, which is technically the absence of rhythm. The first type of ventricular dysrhythmia we're gonna discuss is a premature ventricular complex, or PVC for short. A PVC is an impulse that starts in a ventricle and is conducted through the ventricles before the next normal sinus impulse. Ventricular and atrial rate depends on the underlying rhythm. Ventricular and atrial rhythm is irregular due to early QRS creating one RR interval that is shorter than the others. The PP interval may be regular, indicating the PVC did not depolarize the sinus node. QRS shape and duration is 0.12 seconds or longer. Shape is bizarre and abnormal. P wave of the PVC is visibility of the P wave depends on the timing of the PVC. May be absent or in the front of QRS complex. If the P wave follows QRS, the shape of the P wave may be different. And PR interval, if the P wave is in front of QRS complex, the PR interval is less than 0.12 seconds. So the P to QRS ratio is 0 to 1, sometimes 1:1. The etiology of PVC may be from a cardiac ischemia or infarction, increased workload on the heart, digitalis toxicity, acidosis, electrolyte imbalances, and hypokalemia. The pathophysiology of PVC have three main physiological explanations, which are enhanced ectopic nodal automaticity, re-entry signaling, and toxic or reperfusion triggered. So the first type is ectopic enhanced nodal automaticity, suggests the foci of subpulmonic valvular pacemaker cells that have a subthreshold potential for firing. The basic rhythm of the heart raises these cells to threshold, which precipitates an ectopic beat. This process is the underlying mechanism for arrhythmias due to excess catecholamines and some electrolyte deficiencies, particularly low blood potassium known as hypokalemia. Another would be a re-entry signaling, which occurs when an area of one-way block of the Purkinje fibers and a second area of slow conduction are present. This Condition is frequently seen in patients with underlying heart disease that creates a differential conduction and recovery due to myocardial scarring or ischemia. During the ventricular activation, one bundle tract's area of slow conduction activates the other tract's bundle fibers post-block after the rest of the ventricle has recovered, this resulting in an extra beat. Re-entry can produce a single ectopic beats or it can trigger paroxysmal tachycardia. The last type would be triggered beats, which are considered to be due to the after depolarizations triggered by the preceding action potentials. These are often seen in patients with ventricular arrhythmias due to digoxin toxicity and reperfusion therapy after a myocardial infarction. So to better understand the pathophysiology of PVC, here is a video on the process of the disorder. So a PVC happens when the ventricles are activated prematurely by an abnormal firing site called an ectopic site, located in the ventricular area. The fact that the ventricular depolarization occurs not from the atria, PVC-QRS complex are not preceded by P waves. Unlike the normal conduction carried out by specialized cells of the conduction pathway, the signal in PVC is conducted through the myocytes of the heart muscles and propagates more slowly, producing a broader QRS complex. Depending on the location of the ectopic site, the resulting QRS complex may also be taller or deeper than usual. PVC typically does not conduct back to the atria, so SA node firing is usually not affected and PP intervals remain unchanged. But a P wave that follows a PVC may not result in a beat if it happens too closely to the PVC. When the ventricles are still in their refractory period, this is referred to as a compensatory pause. The clinical manifestations of a PVC would include a skipped heartbeat, a strong beat, palpitations, lightheadedness, chest pain, pain feeling, fatigue, and hyperventilation after exercise. Medical management for PVC includes administration of medications such as antiarrhythmics, which are agents that alter the electrophysiologic mechanisms responsible for PVCs. Beta blockers and calcium channel blockers may also be given. Electrolytes replacement, such as magnesium and potassium supplements, are also given. Radiofrequency catheter ablation treatment is advised for people with ventricular dysfunction and frequent PVCs. This procedure is a way to destroy the area of the heart tissue that is causing the irregular contraction characteristic of PVCs using radiofrequency energy. An implantable cardioverter defibrillator may also be given to a patient with PVC. Lifestyle modifications are recommended for the patient. The outlook for patients with premature ventricular complex varies on the severity of the underlying disease causing the PVC. Complete recovery from this disorder must also be a recovery from the underlying disease. For the pathophysiology of ventricular tachycardia, we must consider the etiological factors resulting into two types of VTAC. First would be from a focal ventricular tachycardia, which comes from hormones, low O2 level, stretching from existing heart diseases, which results into a Purkinje fibers cells gets irritated due to these etiological factors. Then fire signals around the ventricular area, causing it to beat fast and in an abnormal rhythm of the heart. From the reentrant ventricular tachycardia, we must consider its etiological factors, which is myocardial scarring. Scar area disrupts the electrical conduction. Signal is scattered along the ventricle, which then leads to fast abnormal rhythm of beating of the heart. From this, there is a decreased ventricular blood filling in the heart. The cardiac output is then reduced, causing an hemodynamic collapse due to the low cardiac output. This may lead to decreased myocardial perfusion, worsening inotropic response, ventricular fibrillation, and even sudden death. Its clinical manifestations include palpitation, lightheadedness, syncope from diminished cerebral perfusion, chest pain, and anxiety. The diagnostics and laboratory procedures for ventricular tachycardia include electrocardiogram, cardiac MRI, and transesophageal echocardiography. An ECG is a test which measures the electrical activity of the heart and records a picture of the heart's electrical activity, allowing doctors to spot abnormalities. For the cardiac MRI, this imaging test uses strong magnets and radio waves to produce clear, cross-sectional images of the heart, and this gives the doctors the ability to look at the heart in more detail. For the transesophageal echocardiography, in this procedure, an ultrasound probe is inserted into the esophagus. This probe uses high-frequency sound waves to create detailed images of the heart. These pictures gives doctors a better view of the heart structures and valve, helping in their diagnosis. Medical management for ventricular tachycardia includes electrical defibrillation, which restores a normal heartbeat by sending an electric pulse or shock to the heart. They are used to prevent or correct an arrhythmia, a heartbeat that is uneven or that is too slow or too fast. CPR is also done to keep oxygenated blood flowing to the brain and other vital organs until more definitive medical treatment can restore a normal heart rhythm. Antiarrhythmic medications are also given to decrease or increase conduction velocity of the body of the patient. Implantable cardioverter defibrillator is used to perform cardioversion, defibrillation, and pacing of the heart for the patient with VTAC. Radiofrequency ablation is a procedure in which an electrical current produced by a radio wave destroys abnormal tissues that are causing the heart to beat incorrectly. And finally, a cardiac resynchronization therapy, which is a procedure that involves the implantation of a device that helps regulate the heartbeat. Prognosis for VTAC varies with the specific cardiac process, but it is predicted best by left ventricular function. Patients with VT may suffer heart failure and its attendant morbidity as a result of hemodynamic compromise. The next type of ventricular dysrhythmia is a ventricular fibrillation. It is a rapid, disorganized ventricular rhythm that causes ineffective quivering of the ventricles. The ventricular rate for VF would be greater than 300 beats per minute. The ventricular rhythm would be extremely irregular without a specific pattern. QRS shape and duration, irregular undulating waves with changing amplitudes. There are no recognizable QRS complex as you can see here. Its etiology may come from coronary artery disease, acute myocardial infarction, untreated or unsuccessfully treated ventricular tachycardia, cardiomyopathy, valvular heart disease, several pro-arrhythmic medications, acid-base and electrolyte abnormalities, electrical shock, and Brugada syndrome. The pathophysiology of VFib starts as myocardium is stimulated by signals fired by irritated ventricular cells due to coronary artery disease, electrolyte imbalances, hypotension or shock, stimulant overdose. Then, the impulse propagates erratically through the variably refractory myocardial cells and establish reentrant patterns. There is then chaotic ventricular depolarization, disruption of coordinated myocardial contractions. Different patterns break up into smaller wavelets. There is then an increased level of disorganization in the heart, The reentrant circuits produce high-frequency activation of cardiac muscle fibers, which then causes the heart to lose its ability to pump blood. Myocardial ischemia worsens and a self-perpetuating vicious cycle ensues, leading to death if there is no medical intervention done promptly. The clinical manifestations for VFib includes lightheadedness or dizziness, palpitations, fatigue, chest pressure or pain, shortness of breath, and fainting spells. Diagnostic procedures and laboratory studies done for VFib includes electrocardiogram, as this test records the electrical activity of your heart via electrodes attached to your skin. Impulses are recorded as waves displayed on monitor or printed on paper. Because injured heart muscle doesn't conduct electricity, normally the ECG may show that a heart attack has occurred or is in progress. Blood tests are also done for doctors to take samples of your blood to test for the presence of certain heart enzymes that leak into your blood if your heart has been damaged by an heart attack. A chest x-ray is done for the doctors to check your shape of your heart and its blood vessels. Echocardiogram is also done, as this test uses sound waves to produce an image of your heart. During an echocardiogram, sound waves are directed at your heart from a transducer, a wand-like device held on your chest. Processed electronically, the sound waves provide video images of your heart for the doctors to check. Coronary catheterization or an angiogram is also done to determine if your coronary arteries are narrowed or blocked. A liquid dye is injected through a long thin tube that feeds an image through your artery, usually in your leg, towards your heart. The dye makes your arteries become visible on X-ray, revealing areas of blockage. Cardiac CT scan and MRI may also be done to give doctors images of your heart to detect the underlying causes of ventricular fibrillation. Medical management for VFib includes CPR to keep oxygenated blood flowing to the brain and other vital organs until more definitive medical treatment can restore a normal rhythm. Antiarrhythmic medications are used to decrease or increase conduction velocity to stabilize the rhythm. Electrical defibrillation is done to restore a normal heartbeat by sending electric pulse or a shock to the heart. They are used to prevent or correct an arrhythmia, a heartbeat that is uneven or that is too slow or too fast. Percutaneous coronary intervention is a non-surgical procedure used to treat narrowing of the coronary arteries of the heart found in coronary artery disease. Extracorporeal cardiopulmonary resuscitation is a method of cardiopulmonary resuscitation that passes the patient's blood through a machine in a process to oxygenate the blood supply. The chances of survival from an index ventricular fibrillation event depend on the bystander's ability to do CPR, rapid availability or arrival of personnel and apparatus for defibrillation, and advanced life support and transport to a hospital. The next type of ventricular dysrhythmia is the idioventricular rhythm. It is also called as a ventricular escape rhythm. When idioventricular rhythm is not caused by a V block, it has the following characteristics of ventricular rate between 20 and 40 beats per minute. If the rate exceeds 40 beats per minute, the rhythm is also known as accelerated idioventricular rhythm. Its ventricular rhythm is regular. The QRS shape and duration is bizarre and abnormal shape. Duration is 0.12 seconds or more. Its etiology may come from a heart block, reperfusion after myocardial infarction, electrolyte abnormalities, heart diseases present at birth, side effects of certain drugs such as digoxin, beta-agonists, and anesthetics. Its pathophysiology starts from as there is no signal received from the SA node due to the etiological factors mentioned. Ventricular cells take the initiative in sending impulses. The ventricular rate is 20 to 40 beats per minute, and that is a reduced cardiac output. The clinical manifestations for idioventricular rhythm consists of fainting, chest discomfort, shortness of breath, peripheral edema, cyanosis, and clubbing. The Diagnostics and Labs for idioventricular rhythm includes physical examination, being able to detect irregular cardiac rhythm and occasional pulse deficits, and electrocardiogram would be to identify the ECG waves characteristics, which are ventricular rate being between 20 to 40 beats per minute. The medical management for idioventricular rhythm includes administering IV epinephrine, atropine, and vasopressor medications to help stabilize the normal heart rhythm. Treatment of the underlying disease is indicated to alleviate the causative factors of the disorder. Emergency transcutaneous pacing is a temporary means of pacing a patient's heart during an emergency, stabilizing the patient until a more permanent means of pacing is achieved. It is accomplished by delivering pulses of electric current through the patient's chest, stimulating the heart to contract. Idioventricular rhythm is a mostly self-limiting rhythm and typically has a benign prognosis. The prognosis of patients with AIVR largely depends on the underlying conditions. The last type of ventricular dysrhythmia is the ventricular asystole, commonly called flatline. Ventricular asystole is characterized by the absence of QRS complexes confirmed in two different leads. Although P waves may be apparent for a short duration, there is no heartbeat, no palpable pulse, and no respiration. Without immediate treatment, ventricular asystole is fatal. For us to easily remember the etiological factors, we can make use of the H's and T's. So the H's consists of hypoxia, hypovolemia, hydrogen ion, hypoglycemia, hyperglycemia, hypokalemia, hyperkalemia, and hyperthermia. Trauma, toxins, tamponade, tension, pneumothorax, and thrombus. The pathophysiology of this disorder starts as the H's and T's etiological factors affect the heart of the person. The heart's electrical system fails to generate ventricular depolarization, which causes no ventricular contractions. When there is no ventricular contractions, there would be no cardiac output. As there are no cardiac output, there would be severe hypoxia and metabolic acidosis. When untreated, it would result to death. Its clinical manifestations include cardiac arrest, lightheadedness or syncope, unconsciousness and unresponsiveness, final gasping, no heart sounds, no palpable peripheral pulses. Diagnostic procedures and laboratory studies for ventricular asystole includes electrocardiogram to check the flatlining of the ECG waves of the patient. Serum electrolytes test is done to check for the electrolyte imbalances being the causative factors of this. The medical management for ventricular asystole includes CPR to keep oxygenated blood flowing to the brain and other vital organs until more definitive medical treatment can restore a normal heart rhythm. Aspirin and vasopressin are given to help stabilize the normal heart rhythm. Transcutaneous pacing as a temporary means of pacing a patient's heart during emergency and stabilizing the patient until a more permanent means of pacing is achieved. The prognosis for ventricular asystole Depends on the etiology of the asystolic rhythm, timing of interventions, and success or failure of advanced cardiac life support. Generally, it is a bad prognosis for this disorder. So now we proceed to the nursing management for the ventricular dysrhythmias. One nursing diagnosis for ventricular dysrhythmias would include risk for decreased cardiac output. Its risk factors may include the altered electrical conduction, reduced myocardial contractility. Our desired outcomes would be to maintain or achieve adequate cardiac output as evidenced by BP or pulse within normal range, adequate urinary output, palpable pulses of equal quality, usual level of mentation, display reduced frequency or absence of dysrhythmias, participate in activities that reduce myocardial workload. Our nursing interventions for this would be to palpate pulses, noting the rate, regularity, amplitude, and symmetry. Document presence of pulses, alternance, bigeminal pulse, or pulse deficit. Auscultate the heart sounds, noting its rhythm, presence of extra heartbeats, and drop beats. Monitor vital signs, assess adequacy of cardiac output and tissue perfusion, noting significant variations in BP or pulse rate equality, respirations, changes in coloration, temperature, level of consciousness, sensorium, and urine output during episodes of this. Another nursing diagnosis would be risk for impaired gas exchange. Its risk factors include alveolar capillary membrane changes such as fluid collections or shifts into the interstitial space or alveoli. The desired outcomes would be to demonstrate adequate ventilation and oxygenation of tissues by ABGs, oximetry within patients' normal ranges, and free of symptoms of respiratory distress. Participate in treatment regimen within level of ability per situation. Our nursing interventions would include to auscultate breath sounds, noting trachos and wheezes. We should also instruct patient in effective coughing and deep breathing. We should encourage frequent position changes, maintain chair or bed rest with the head of bed elevated 20 to 30 degrees, semi-Fowler's position, support arms with pillows. Place patient in Fowler's position and give supplemental oxygen. Another nursing diagnosis would be activity intolerance. Its related factors include imbalances between oxygen supply and demand, generalized weakness, prolonged bed rest, immobility, and the defining characteristics would be the weakness, fatigue, changes in vital signs, presence of dysrhythmias, dyspnea, pallor, and diaphoresis. Our desired outcomes for this would include to participate in desired activities, meet own self-care needs, achieve measurable increase in activity tolerance evidenced by reduced fatigue and weakness by vital signs within acceptable limits during activity. Our nursing interventions would be to check vital signs before and immediately after activity, especially if patient is receiving vasodilators, diuretics, or beta blockers. We should also assess patient's general condition. We should provide assistance with self-care activities as indicated, intersperse activity periods with rest periods. Also encourage patient to have adequate bed rest and sleep. We should assist in client in ambulation. So that's all you need to know for now. Thank you and God bless.